Well, good morning, everyone. It's 9:45, so we'll actually start. Thank you all for joining our session this morning on rheumatoid arthritis, and we're making progress in 2016. My name is Paul Haddad. I'm the Chief Development Officer with the Arthritis Society. And this morning I have the privilege of introducing Dr. Michael Starr to take us through the presentation. But before I do so, if you don't mind, I'll just cover off. Okay. I'll cover off, sorry about that. I'll cover off a couple of logistics items for us. We have about 45 minutes of presentation time, followed by about 10 minutes of Q&A. And I'll ask if you can please keep the questions general in nature. It's not intended to be a one-on-one consultation with Michael Starr. And we have, this is a webinar session, so for those of you connecting virtually, you're able to ask questions through the app. Hopefully you've downloaded the QFA app and you can send in questions, and I'll find those questions and I'll ask them at the end of the sessions. I would like to thank Pfizer as our sponsor for this session, for making the session possible for us this morning. And without any further delay, allow me to introduce Dr. Michael Starr. Dr. Michael Starr is a member of McGill University Health Center, rheumatology in the rheumatology division. Formerly head of training in rheumatology at McGill, he continues to teach in continuing education programs in Montreal and elsewhere in Canada. He has been involved in many therapeutic clinical trials in the area of inflammatory arthritis and has published several articles and books, and recently co-authored a book for the general public on the role of nutrition in the treatment of arthritis. In addition, he is the rheumatology editor for the Canadian Journal of Diagnosis and regional director of the Patient Partner Program Against Arthritis in Montreal. Without any further delay, allow me to introduce Dr. Michael Starr. Thank you.
Thank you very much for the intro, and thanks to the Arthritis Society for putting together such a great, important event, and for our sponsor today also, which is Pfizer. Can everyone hear me well? Good, okay. So we're going to run through a topic that's a little bit close to my heart. I've been very involved in the inflammatory forms of arthritis, which we'll explain a little bit. The talk will be some generalities, and I'll go into a few sort of specifics that are a little bit more scientific, and hopefully it'll be clear to all of you guys at the end. And I put the topic as, are we making progress in 2016? And it's pretty interesting because I'm going to date myself a bit, but having been doing this for over 20 years now, our field has changed dramatically. We've had really, it's much more exciting for me to be a physician in this field since we've had the development and advent of so many new drugs that are out there for rheumatoid arthritis. So probably some of you in the room have this condition. Maybe others of you are just here to listen in on some new things. But really the field has changed a lot, and I'd like to show you that. So my conclusion, I can tell you right now, is that we have progressed, but we still have a way to go. Whoops, am I going backwards? Going backwards. Here we go. Okay, good. So, does anyone know what this is? This is an old slide. This is leeches, right? Okay. And so this was with the old way of treating diseases. And in fact, probably not that long ago, this slide might have applied to rheumatoid arthritis, actually, because we didn't have that much to offer patients. And this is sort of the concept of putting leeches on and sucking the bad humors out of the blood to heal people. And in fact, in some communities around the world, this actually is still done. Okay, actually, believe it or not. So I'd like to think that we're past this and we're onto some new things, but I just wanted to start with that. So there's many kinds of arthritis. So I think we have to set the stage because we're talking today really about rheumatoid arthritis, which is a very specific thing. And when we sort of throw the word out arthritis, people have sort of an image of, oh, I'm getting a little older, I'm getting a little creaky, some aches and pains, which is true, that happens, but that is far and away more common to be osteoarthritis. And we mix up the terms a lot. And I want to be very clear that we're talking about something very different today. There's probably over 100 kinds of arthritis. What we're talking about today is the inflammatory form called rheumatoid. There are other forms of inflammatory arthritis that can behave in a similar fashion. People who have psoriasis of the skin can get an arthritis that looks like rheumatoid, and we call that psoriatic arthritis. Then there's a spinal form of arthritis, which can also have other joints involved, that we call ankylosing spondylitis or spondyloarthropathy. These are the three most common forms of inflammatory arthritis. And in fact, some of the medications that we're going to talk about today and some of the newer treatments actually apply to all of the inflammatory forms of arthritis. The most common, though, is osteoarthritis, and that's not what we're going to talk about today. So the medications, by and large, that we use for rheumatoid, we don't work very well in osteo. So what is inflammation? That's the concept that we need to start with. It's very different than, let's say, someone, as I mentioned, getting older, you're having some wear and tear, some degeneration in your joints. That's typical for osteo. But rheumatoid is an inflammatory condition. For some reason, the immune system starts to create inflammatory cells. It's almost as if the immune system turns on yourself and creates what we call an autoimmune state, and there's inflammation coming inside the joint. Now, what does inflammation mean clinically for someone who has inflammation? Usually that's manifested by swelling. Oftentimes there's some redness, there's heat in the joints, there's a lot of stiffness, very different than the degenerative type. So if I just show you here, this is on the normal side, on this side of the slide. We have the two big bones that come together to make a joint, as an example. There's fluid, which is the blue inside the joint, and the joint has a lining of cartilage, this sort of whitish kind of area. So what happens in chronic inflammation? We get a proliferation of the fluid and what's called the synovium, which is the tissue lining of the joint. And what happens is, if this inflammation goes untreated, it starts to eat away at the cartilage lining of the joint. That whitish lining over here, it starts to get eaten away, getting down to the bone underneath, and then causes damage to the bone. Completely different than osteoarthritis. And so it causes what we call erosions of the bone, which are little holes in the bone, and thereby the whole cycle of damage, potential difficulty with function, and so on occurs. And we'll get into that a little bit more. So I just thought I'd start off with a case, and just to sort of set the stage for a typical type of case that might come into my office. So here's a young woman who's a runner and feels that she's getting some tenderness and some stiffness at the balls of her feet, underneath the feet, where the toes sort of join the foot. And it's wakening her at night, and she figures, well, I'm a runner, so I guess I'm getting some pain in my feet, but she's kind of on the young side. 2 months later, she gets some swelling of a knee. It's a bit unusual. And she goes to her family doctor, her GP, gives her an anti-inflammatory pill like ibuprofen or naproxen, standard sort of things. She feels a bit better, but then several months after that, she notices that she has some swelling in one of her fingers, the knuckle of her hand, right over here. And then she realizes, this can't really be my running. Obviously, I don't run on my hands, so it's something else might be going on. The morning stiffness is getting a bit worse. And it turns out she works as an administrative assistant, and she's 1 year postpartum. So that's, for a physician, that's the key to this whole thing, is that 1 year postpartum, we know that several months after delivery, we sometimes see onset of rheumatoid arthritis. It's not uncommon for us to see that after pregnancy. She's having pain in small joints of her hands, left knee, difficulty to make a fist. She's having trouble gripping things. She can't wear her shoes anymore. Now she's getting a little numbness in her hands, something called carpal tunnel, which I bet some of you are aware of, where the nerves get pinched in the wrist because of swelling. And so she's developing other symptoms. Her stiffness now is lasting quite a long time and becoming more of a problem. So here's what rheumatoid arthritis looks like in fairly early stage. Okay, and this is what I want to kind of get across, and we try and preach this and teach this a little bit to some of the family doctors and young doctors who are in training and so on. They have to realize that if you see a hand like this, it's serious. Because on the surface, if you look at this, I'll bet most of you would say, well, I don't know, it doesn't look that bad, right? Okay, it's sort of, all we're getting here is, you can imagine that there's some soft swelling here at these joints, maybe a little bit here, but this is the patient that I want to see. I want to see this patient now. I don't want to see this patient a year later, all right? And that is where the idea of education and raising awareness among physicians, among patients, that this is not a normal situation. This needs to be dealt with. The other thing that's interesting is, look at the nails on this patient. What do you think? Those nails are kind of yellow. Anyone have an idea what that might be from? Smoking. Okay. So very interesting, because this is fairly new information. We now know that smoking, of course, smoking is not good for you. We all know that. But smoking, in fact, now is thought to be a risk factor for developing rheumatoid arthritis, an independent risk factor. So if you smoke, you have a higher chance of getting rheumatoid arthritis. And if you have RA, rheumatoid arthritis, and you smoke, you're not going to do as well. You don't respond to treatment as well, and your outcome and prognosis is worse. So we're going to touch on that a little bit, because the treatment, I'm going to focus a lot on medication, clearly, but this disease is not just treated by meds, all right? It's a whole lifestyle modification issue that we're going to touch on. Diet, stop smoking. There's a lot of issues, not just giving people a pill and everything gets better. It's not exactly like that. So the reason that I wanted to see the patient here, the picture on the left, as I mentioned, this is very, very early stage of RA. Right over here, just a little bit of swelling, doesn't look so bad. It's because I don't want this to happen. All right. So this is the classic deformity that people will get with rheumatoid arthritis in an untreated patient. So really, if I see this now coming in my office, I think it's kind of tragic, actually, because we have the tools to stop this. This should not happen anymore. We shouldn't see this type of evolution with the tools that we have available. So rheumatoid arthritis, I mentioned a little bit about this. It's an autoimmune disease where your immune system attacks healthy tissues, and in this case, it's your joints, causing inflammation. The interesting thing about rheumatoid is it's a systemic disease, meaning that it's sort of right through you, in a sense, and has other symptoms associated with it, and can affect sometimes other organs. There can be involvement of the lungs in rheumatoid arthritis, the eyes, for example, the heart, rarely. So it can be really a disease of inflammation that affects you throughout. And it's a chronic disease. We still aren't really able to talk about the word cure yet. We're getting there, but we're not there yet. How common is it? About 1% of the Canadian population suffers from RA. If you think about what 1% of adults have RA, and women are more affected than men, about 3 to 1. It can occur at any age, very different than, let's say, the osteoarthritis that I was talking about before, which tends to be older age, more sort of in the 50s and 60s. This can occur at any age, and in fact, as many of you may know, we even have juvenile rheumatoid arthritis that occurs in childhood. There's a huge division at the MUHC of an excellent group of juvenile pediatric rheumatologists. Some of my patients who are now adults have had rheumatoid arthritis that started when they were just a few months old, 2 years old, 7. I see this. I have many patients like this. And I think this is a very unknown thing. People don't realize it when they think about arthritis, and they can't imagine that a child could actually have arthritis. What are some of the warning signs? Well, we pay a lot of attention to swelling. So swelling of at least 3 different joints is a warning sign. Long-standing morning stiffness that's lasting prolonged, not just the sort of, I'm sitting for a while, I get up and sort of 2-3 minutes later I start getting moving and I'm okay. That's very typical of osteo. The rheumatoid patients are very stiff and it can last for hours, sometimes all day. And because it's a systemic disease, as I mentioned before, we have patients who are very fatigued, which is a big problem to deal with. They feel weak. Sometimes even fever, weight loss, we see that as well. We don't know what causes it. We're pretty sure there's a genetic component, and there's a lot of evidence to that. And there's studies ongoing looking at genetic profiling of patients. So what we think is that you have to have the right genetic profile and then an environmental trigger that might start the process. So someone who doesn't have the genetic profile, who's exposed to the same environmental trigger, may not develop the disease, whereas someone who carries the gene might. So there's a lot of research in this area. I still think it's a little bit in its infancy, in a way, of being studied. But other interesting things, and I mentioned this a little bit before, the pregnancy issue, I can't tell you how many times I've heard people come in and say the onset of their disease was after an acute life stress, either an emotional shock or a physical trauma, and the disease starts after that. So we think there's probably something going on at the immune system level that's triggered by acute stress. Smoking, I mentioned as well as a risk factor. So let's get into the heart of this then. What are we doing about all of this? So why do we need to treat people early? I think I showed you that slide, which I think sort of says it all. But we know that in untreated rheumatoid arthritis, you will have rapidly onset of deformity, damage to your joints, and potential disability. An old statistic, which I'd like to tell you is changing, is that if you have rheumatoid arthritis, by 10 years into the disease, only 10 years, you're talking about a disease that hits young people and will be for life, 10 years into the disease, 50% are no longer able to work. All right? It's a pretty staggering statistic. It's an old number that I'm giving you. A number of years ago, before we had better treatments, I don't know the current stat on that. It's changing and it's better. But just to tell you how devastating this disease can be, we get early joint damage, and in fact, historically, patients poorly treated with rheumatoid arthritis actually don't live as long as others. Okay, and the old data again was that it was about 6 or 7 years, and most of that has to do with chronic inflammation and the link to heart disease in people who are chronically inflamed year after year after year. There actually can be a big problem here. So it's a serious problem when you consider the 1% of the population. And I think that the knowledge about this disease and what's out there in the public, I think, is quite poor. So how do we approach RA? We really talk about this window of opportunity. And we preach, as soon as we make the diagnosis, we want to get on top of this right away. We want to shut down the inflammation right away before we end up with all the complications like I've been talking about. So the analogy would be something like, if there's and I think this is a good visual for people. If there's a fire in the kitchen, you don't wait till it spreads through the house. You put out that darn fire right away, right? And that's the same concept. As soon as we see this inflammation, we want to turn it off, okay? And we think we can. And the idea is, if you look at the left side, this is early rheumatoid arthritis. Again, similar slide that I showed you before. Doesn't look that bad, right? But we don't want it to go into that intermediate form and then the more severe deforming. Once that happens, I can't change it. I can make people feel better with this, maybe with some medications and lifestyle changes, but I can't stop the damage that's already happened. So the key is that RA really is like an iceberg. What I'm seeing at the surface, you have to think what's going on underneath the surface. That picture I showed you of eating away at the bone underneath, that's what we don't see, and that's what we need to shut off. So how do we diagnose it? Well, there's the history that the physician takes. We examine patients, and we do a lot of imaging now. So we'll do x-rays, but in fact, we're way past x-rays. We're doing a lot of ultrasound diagnosis, MRI diagnosis, showing damage that is occurring much earlier. X-rays are great, but they're kind of rudimentary. They've been around for a long time. They don't pick up subtle changes in the bone. It takes a long time to see a change in the bone on an x-ray. So here's an example of an x-ray that actually I would have reported as normal. All right, but if I do and look at that area right there, if I do an MRI, amazingly, we see a little hole in the bone where that arrow is. So it shows us that the damage is actually occurring much earlier than we think, because we might not have treated this patient saying, oh, well, your x-rays look okay. But in fact, using these types of techniques has helped us a lot. This is an important slide. It's a little bit technical, but I'd like to walk you through it because it's going to be important for the rest of the time that we have together to talk. This is a slide that shows what happens in rheumatoid arthritis when it's not well treated, and the reason why we need to turn it off early, and that the new drugs that we have are doing this for us. So if you look at the axis over here, this is the severity of the disease over time, and at the bottom axis is time. If you look at the red line that goes straight up, what it means is over time, you're getting more and more damage to your joints. The x-rays, the MRIs are looking worse and worse. You're getting damage. Damage means deformity, all right? So look at the red line. Over time, this is in a patient that we just let go. Okay, just let's see what happens to you. Over time, the x-rays are going to get worse and worse. Now, look at the green line, the inflammation level. Early in the disease, the first few years, sorry, but this red thing isn't working too well. Here it is. The green correlates and follows the X-ray damage. But over time, interestingly, as you continue to be inflamed, you can control some inflammation, but it's a little bit too late. The X-rays are getting worse and worse and worse, right? Now, if we look at the black line going up, interesting, that corresponds to the disability of a patient. It means your functional capacity getting worse and worse. And look how interesting this is. The functional capacity getting worse, the black line, follows perfectly along the red line, okay, over time. Meaning that if your X-rays and your MRIs are getting worse over time, in other words, damage to the bones underneath the surface of what we see, you are going to be more and more disabled. That's what it means, even if we turn off the inflammation. So this concept changed the entire treatment of rheumatoid arthritis, because for the first time we realized, well, it's okay. People with RA, what do they come in with? They're stiff. They have pain. That's what they want treated, which we understand and should be. But it wasn't just enough to say, okay, I'll give you a pill and your pain is less and you're okay. We need to stop the damage that's happening at the X-ray level over time in order to shut off the potential of becoming disabled from this disease. So this concept really changed things, and the development of new drugs which could stop the damage has been what's turned around this whole field. Okay, so I hope I'm still with you guys. So what I'm trying to show you is that RA is a pretty serious disease. And I like to show this slide. Some of you have heard me speak before, might have seen this, but I like to put this up. Do you know who these two guys are? That's Saku Koivu and Mario Lemieux, both fantastic hockey players who have now retired, some of the best ever. What do they have in common besides being hockey players? Sorry? Cancer. They both had lymphoma, okay, which is a blood cancer. So it's interesting. They both had lymphoma. They both interrupted their careers to get treated, and they both went back to resume their careers incredibly successfully. All right. And what do we think of in society? I mean, if someone uses the big C word, cancer, that's the most terrifying thing that anyone could hear, right? Cancer. Well, I'm going to turn your way of thinking a little bit, because I'm going to ask you, if they had rheumatoid arthritis and not cancer, would they have actually gone back to resume who thinks they would have been able to resume their careers? I don't think too many of us would say that, right? So it's an interesting kind of concept because, again, cancer, I'm not saying cancer is a good thing, clearly not, okay? But, it can be treated, and some patients can do fabulously well and get back to their normal lives, but a rheumatoid patient, it's a pretty devastating diagnosis, okay? And I think that this concept is not really out there. I think people don't appreciate it. I think that the public in general feels, oh, you have arthritis. Well, okay, what can you do? I guess you're getting a bit older. That's the way it goes, So, but it really isn't true. So I wanted to hit that home. So what are the treatment options? As I mentioned before, we have, of course, medications, which we're going to talk more about, but it's this whole concept, this global concept of how we treat the disease. So exercise, if we go around the circle, managing pain and stress, lifestyle choices, dietary changes. Everyone asks me about diet and supplements all the time. And there are some things that are reasonable out there. Weight control, stop smoking. These things can have a big impact on the outcome of the disease. Fatigue management, how to do joint protection. There are occupational therapists and physiotherapists who can help you with these things. And of course, medication is a bit more where I come in. So the basic approaches are patient education, which is what you guys are doing by sitting in the room today and being part of Arthritis Society activities. The conservative treatments are the lifestyle changes. Most patients will try anti-inflammatory medications. Most patients will have tried what we call DMARDs, disease-modifying arthritis drugs, which we call second-line medications, and I'll mention a few of those. And then we're into the biologic drugs, or in some cases, drugs that aren't yet on the market, and some of the patients will end up in trials, clinical trials with experimental type drugs. So if we just start from the conservative side a little bit, the internet's a great thing, okay, and people get a lot of information out of the internet, but some of it can be scary, some of it kind of isn't true and isn't right. So I encourage you, don't think, well, I can't speak for everyone, but if you've heard something or talked about something on the internet or read something, come in and, if you're my patient, tell me about what you heard. Let's talk it out, okay? Because some of the stuff is not true, but some of it may have some value and might be something reasonable to pursue. I caution you about some of the cures on the internet, and you have to, it sucks people in, right? This is a chronic disease. People are frustrated. You're looking for an answer. You're looking for a cure. And, when you start seeing things like this, don't even think about buying another pain relief product till you read this. Scientists develop an all-natural secret formula that stops crippling arthritis. In 15 minutes, okay? 15 minutes, imagine. No drugs, no surgeries, no pain. So you have to be a little careful about just buying into these things and wasting your money. It's probably better to speak to your physician about things like this. The herbal supplements, there's a number of them on the market that are very popular and have some validity, things like glucosamine and chondroitin, MSM. I didn't put turmeric on here, or curcumin. Very popular right now. A lot of people are adding curcumin to the diet. I was involved myself with Kim Ari, who I don't know if she's in the room, but she's, I think, speaking next in this room. So Kim's a dietitian in Montreal and has been involved with me in sort of talking about healthy diet for patients with rheumatoid arthritis. So there's literature out there. There's things that you could seek out that are not just internet-based and that might be of value for you. So the DMARDs, almost everyone ends up on a DMARD. These are disease modifying. So what that means is it's not just giving you a pill to help your pain. That's great. But what we want to do is we want to shut off the disease, right? We want to shut off the damage that might occur. So here we enter into the second line drugs, the disease modifying drugs, which we think can actually modify the course of the disease to reduce joint damage. There's many of these on the market, and I bet a lot of these drugs will be familiar to some of you in the room. Gold injections is an old thing, Plaquenil, methotrexate. Almost everyone with rheumatoid arthritis has probably tried methotrexate at some point. It's a very standard drug. We sort of call it our anchor drug before going on to other things. And there's a variety of them. So you can see there's a list here. My gosh, there's, I'm listing about 8 or 9 drugs here, and there's even more actually. So you can sort of ask the question with so many drugs, like, that's pretty good. Well, why do we need anything new? Okay, well, there's a bit of a problem with the DMARDs. Most of them will lose effect over time. So if you look at the statistics, even if someone will do well at the beginning, they tend to lose the effect, unfortunately. A lot of side effects with the disease-modifying drugs, and again, take a drug like methotrexate. It can work very well, but people complain all the time bitterly about some of the side effects to it, and we have to stop them. And they don't always work that well. Patients get a little bit better, but they don't necessarily stop the damage that I was sort of talking about. So, RA is a really, really complex disease, okay, which I'm going to show you, and this is where a lot of the research is in. So this says, this is the Wicked Witch saying, forget the slippers, I want some of Tin Man's oil. So I wish it was that simple, okay, but it's unfortunately not. And this just, this is not something for you to kind of like take away too much from the slide. I just want to show you the complexity of rheumatoid arthritis. You've got all these immune cells talking to each other. You've got T cells, and you have things called B cells, and you have something called an APC, an antigen-presenting cell. And they're all producing different substances that are called cytokines, something called TNF, other things called interleukins. All of these are interacting with each other, very, very complex. And this is where, bench research, trying to figure out how to stop some of these inflammatory mediators. The most common one in the past while has been the TNF drug, and the effects of these on the bone level, causing bone damage. So it's a very, very complex thing, and it can make your head spin a little bit like this is the London tube system. If you ever tried to navigate that, it's pretty complex. So despite all this and the complexities of it, and a little bit of a dreary outcome that I've been showing you about what might happen in this, there's a lot going on, and I think there is some light at the end of all of this. And there are newer therapies. And, this is not just sort of talk, this is actually happening, and it's been going on for at least the last 10 years or so that we've had a new evolution in treatment. So what's happened? It's really the era of the biologic drugs. And biologic drugs are targeted therapies. In other words, that complex slide I showed you, we've developed biologic drugs that target certain elements in the blood that are causing the inflammation, these things called cytokines. So we have things that block TNF, for example, or block interleukin, or block something else called JAK. Again, the science is beyond for today's lecture, all the details of it. I certainly can answer questions if people are interested. But to understand that these are modulating the immune system in a very different way than what we had available to us. Previously, we sort of just blasted the immune system globally. Now we're trying to target certain things that might actually be causing the inflammation and the bone damage. And these come, most of them, in injectable form. So there's intravenous drugs, there's subcutaneous injections that are available, which is an injection just under the skin, the way, let's say, a diabetic might inject themselves. There's a variety of products like that. And now we have newer, they're not biologics, but they're newer oral pills that are available that are called small molecule drugs that are actually really interesting and relatively new compared to some of the injections we've had. And these are, by and large, antibody technologies. So they're called monoclonal antibodies, or they inhibit receptors of some of these cytokines that are driving the inflammation. So again, busy slide, but just to tell you, and I want to bring out the names of some of the drugs. These are the anti-TNF drugs. So they block specifically something called TNF, which stands for tumor necrosis factor. And these drugs are all TNF inhibitors, which have now been on the market since about roughly 2002. I personally was involved in some clinical trials with some of these drugs before they were even launched on the market. And so we had a group of our patients who needed these drugs so badly back in the early 2000s that really turned things around for them. But we didn't know much about them. We were kind of, we were going a little blind. And now time has gone by and they're no longer experimental. They're no longer new. They're pretty much standard. And patients who are suffering and not responding to the initial disease-modifying drugs like the methotrexate drugs, Plaquenil, and so on, there's a big role for moving on to these drugs. And so just to tell you, there's Enbrel or etanercept, which is an anti-TNF agent that's given as a subcutaneous injection once a week. Humira or adalimumab is given every 2 weeks. Remicade is an intravenous drug. It's also infliximab. Simponi or golimumab is a subcutaneous injection given once a month. There's Cimzia or certolizumab. I'm going to make you say all these afterwards, by the way, backwards, okay, which is also given every 2 weeks. These are all, most of them are subcutaneous injections, and they're indicated, if you look at the bottom, we're using them in rheumatoid arthritis, we're using a lot of them in psoriatic arthritis, and also in ankylosing spondylitis, if you remember those inflammatory diseases that I mentioned right at one of the first slides. So these drugs have been in common use now, several of them for 10 to 15 years. Now, as things have evolved, we're beyond the anti-TNF drugs, but we have targeted other mechanisms of action, which are the non-anti-TNF biologic agents. So these are drugs like Orencia or abatacept, which is given both as an intravenous or a subcutaneous injection, and that targets T cells rather than specifically the TNF. Rituximab or Rituxan is an intravenous drug given every 6 months. It's a B cell inhibitor, and it has been approved for use in rheumatoid arthritis, and it also is used to treat lymphoma, interestingly, lymphoma cancer. There's a drug called Actemra or tocilizumab, which is also given either intravenously or subcutaneously. This is an interleukin-6 inhibitor. Okay, again, different. And there's one of the first drugs that came out, actually, it's not used that often, but still has a role, called Kineret or anakinra, is an interleukin-1 antagonist. So you can see how many choices we suddenly have. The anti-TNF drugs have generally, because they've been around for the longest, they generally tend to be the first line biologics that we use. Not in every case. Sometimes a patient will fit a profile better that they should start off with something like a T cell or a B cell inhibitor. But most of the time it's an anti-TNF drug. And if patients aren't doing as well, we sort of move on and we have other groups of drugs that we can sort of choose. And again, the non-anti-TNF drugs are only approved for rheumatoid arthritis versus the TNF drugs, which can be used in psoriasis, psoriatic arthritis, ankylosing spondylitis, and so on. There are some newer developments. I mentioned that we now have some pills on the market that are not technically biologic drugs, but they're called small molecule drugs. They work a little bit differently. They work inside the cell rather than in your bloodstream necessarily, a little bit different. And these are called JAK inhibitors. They inhibit a certain pathway called the JAK pathway. And there's one that's been on the market now for a couple of years called tofacitinib or Xeljanz, which is become quite popular. And again, it's a pill, so some patients are looking for that and aren't so happy necessarily about an injection, although most patients, once they start with the injectable drugs, find that it's not such a big deal, and they're actually quite happy with it too. But it's an alternative, and there's new JAK inhibitors in development that aren't yet on the Canadian market. And there are also other drugs in development now that are also interleukin-6 inhibitors, and there's new B-cell inhibitors and so on. So this whole field is really exploding from a research point of view. The other thing that's happening now, and this is sort of, again, a bit hot off the press, are something called biosimilars. For you guys, you can think of a biosimilar as a generic drug, a generic biologic drug. Okay, so you know how if you go to the pharmacy for Tylenol, you might get acetaminophen, or you might get Adasol, or different things that are all the same active ingredient in the drug, but they're generic forms of the original Tylenol, for example. We're now having biosimilar drugs. They're not technically called generics, but they're biosimilar. In other words, copies of the original drug, like, for example, Remicade or infliximab. There are now copies of that on the market that are a little bit cheaper. Okay, and there are other ones coming. Another one was just approved for a copy of Enbrel, or etanercept is now on the market. So these are similar drugs to the biologic originator drugs, but it's all coming, and there's many of these that are being developed in the market. And so for us as physicians, we're also trying to figure out how we deal with all of this. And we're a little bit cost conscious, so we have to think a little bit about the expenses of some of these drugs. The biologic drugs are costing, most of them are between $15,000 and $20,000 a year. Okay, so very, very expensive, big hit on the healthcare system. So with cheaper medications coming out, I think we have to be a little cognizant of this, but we're learning about the role that these biosimilars will have in the future. And of course, there's newer targets all the time in development. If we looked at that fancy pathway of all the cells talking to each other and so on, there are new targets and sites that people are looking at to try and develop perhaps even new and improved versions of some of the biologic drugs that we have. So what have the biologics been able to do for us? Remember the slide I showed you before about the damage occurring over time, and that damage following the X-ray damage, and disability following that. So the more damage, the more disability. So this is, I think, again, just an important concept that I'd like you to show you, and I think this is hopeful, all right? So if we look at this, here's again, rheumatoid arthritis. This is structural damage. In other words, X-rays getting worse over time, MRIs getting worse, more damage. And remember that damage correlates and coincides with disability over time. So here we have a rheumatoid arthritis patient early in their disease, and if it's untreated, the green line, the natural course, if you just let it go, X-rays will get worse and worse and worse, disability will get worse. Now what if we intervene? We intervene right here where this arrow is. We give a patient a medication. Well, a really good medication, what would it do for us? Well, you'd feel better, but it would also slow down the disease, slow down the damage that we're trying to prevent. If you had a super drug, excellent drug, what it would do is as you intervene right here, it stops the progression sort of cold, stops it in its tracks, all right? So take a look at this picture, okay? And then we'll look at this. So this is a patient treated with a biologic drug from a clinical trial called the ATTRACT trial. It happens to be the drug infliximab or Remicade, but this could apply to pretty much any of the biologics. So here it is. We have the disease, and we're treating it right over here, okay? If we had, remember, I'm going to go back. Look at this line here, the yellow line. If we had a pretty good drug that could slow things down, it would follow this red line. I think you'll agree with me, it sort of follows the red line. So that would be a drug like, let's say, methotrexate, or gold injections, or Plaquenil, or sulfasalazine, all these DMARDs. If we had a good, it's good, okay? And it might slow things down a little bit. But if we had a really good drug, as you intervene, the line would flatten out, just like this, prevention, complete prevention. And this is actually, from that trial using a biologic drug, that's exactly what happens. So intervening here, we stop the disease cold, it doesn't progress. So this was the first information, this goes back a few years, the first information that we said, wow, something good is happening here. We really are into a new era of treatment that is really turning off this disease. And if we can do that, we're really ahead of the game. And that is really what this whole new biologic era and the new treatments that we have in the market has been able to do for us. So it's very exciting for us and for you guys, really. So I'm talking about all these drugs as if they're the best thing since sliced bread. But of course, everything comes with a cost, financial cost, and also the potential for side effects. It's just, unfortunately, there's nothing that we can give, nothing we can prescribe, whether it's simple analgesics, simple pain relievers, or fancy drugs like this. There's always going to be some risk. We can talk about that if you have questions, but our experience now over 10 or 15 years has been that the drugs so far have been pretty darn good. We have seen side effects. I won't mislead you and say anything is perfectly safe. We've never seen a problem. These drugs are manipulating your immune system, so you have to expect that there could be some risk. The major risk of all of the drugs has been increasing your risk of infections. It's not that high, but you will have a slightly increased risk compared to the normal population or compared to other rheumatoid patients who are not receiving these drugs. There are a variety of other side effects that can occur. Serious infections, the biggest one. There's been a lot of discussion. People are always worried, and I've actually had patients in my office come in when I offer them drug like this, and they'll say, are those the drugs that cause cancer? And it's absolutely not true. Absolutely not true. I think a lot of this is American TV, American commercials, which are, as many of you have probably seen, you know how they show people, you know, playing in the park with their kids, and then all of a sudden they list all the side effects that can occur in 15 seconds or less, and it kind of sounds frightening. But they really don't cause cancer, so I don't think you really, it's a big worry. Discuss it with your physician. There are some neurological problems, something called demyelination, very rare, and you could have some other problems that are quite rare. The thing that we see the most are probably a slight increase in infections. So just to come to the end, we have our old treatment. This is before the year 2000, so we're 15, 16 years ahead. What was our emphasis? We were really treating symptoms. Patients would come in and say, okay, you have pain, we'll give you something for your pain. We'll get you feeling a bit better, which was all we could really do. We weren't as aggressive with the treatment. I don't like the word, patients don't like to hear the word aggressive when you're giving medications, but it is somewhat like that at the beginning. And we were using a lot of anti-inflammatories and methotrexate, but things have really, really changed. Now, we're not just talking about symptom relief, but we want to stop joint destruction. We want patients to be able to function. We want them to be able to do things at home, be with their families, cope socially, cope at work, and so on. We want to prevent damage and destruction of joints. And so by doing, the concept is earlier and aggressive treatment. We always start with methotrexate, but we move on quickly to biologics. So our emphasis really is on early type of therapy. So I like to use this quote that really, although we like to get to patients early, it doesn't mean if it's not early that we can't still treat you and still have prevention. So it's never too early, never too late. And just to summarize a few key messages, this is a serious disease, okay, and it needs to be recognized as such. And I personally have been involved in education at the resident, student, family doctor level, trying to tell people that just the word arthritis, it doesn't mean that all arthritis is the same. This is a disease that deserves attention and deserves to be seen early and deserves to be treated. We have to use these disease-modifying drugs and biologics early in order to turn the disease off. The biologic agents are not experimental anymore. They're here. There's new ones on the market, new developments. We're using them commonly, and we're seeing excellent results. Early diagnosis and education is really the key. So, again, the old proverbial tip of the iceberg, this now referring to treatment, is that we're scratching the surface now, and there's a lot of excitement in new drugs. And you know, being part of things like this Arthritis Society event and educating yourselves and helping to educate even your doctors who don't know much about this, I think is really, really important. So as I mentioned earlier, you know, from when I started off, it's actually true. It's actually so much more fun and so much more exciting for me to be a physician in this area because I have so much more to offer patients and so many more tools. And as a result, I think it's a good time to be a patient too, you know, if you're unfortunately stricken with a disease like this. And I'm just going to end with this. I just wanted to show, you know, it's an ancient disease, rheumatoid arthritis. And so I just found this old picture of this guy who's obviously got tremendous deformities over here and sort of sitting in a wheelchair. And you can see the makeshift splints from, that's how they used to do. But again, we can utilize our physios and our occupational therapists to help with things like this. But this guy was pretty innovative, and he was pretty skilled as a painter. And this is how he actually used to paint with all these deformities. Does anybody know who that is? That's Renoir, okay? And Renoir had, severe rheumatoid arthritis. And imagine, it's said actually that some of his most famous paintings were done towards the end of his life when he was severely crippled and disabled like that. Those were pictures of him. And unbelievably, he was able to create this amazing art. So, he did pretty well for himself, but I kind of wonder if he had lived in the biologic era, imagine what he could have accomplished. Although, again, he did pretty well. So this is a long time ago. So thank you for your attention. And how are we doing on time?
We're doing okay.
Great. So thanks again.
So thank you, Dr. Starr. And again, thank Yes,
there's a microphone over here. Do you want them to go up to the mic?
Yeah,
Because
if
if
they
it's
can,
on-
that'll be great.
Yeah.
Exactly, because it is webinar as well.
Is it? I don't know.
Is it on? Yeah.
Thank you.
I just have a question, like for medication like Humira, which is an antibody. It's probably possible that we develop antibodies against the medication. And is there a way to test, to like in the blood, is there a test that we can do to see that? Because sometimes it cannot,
So
then
it's
the medication is not good anymore because you
Right.
develop.
So just to be clear, a drug like Humira in this case is called a monoclonal antibody. And because it's almost any drug, right, is a foreign substance that you're injecting into yourself. So your body's immune system can recognize that as being foreign. And so it can produce antibodies against it so that it won't be as effective. And that's been a problem with some of the drugs. Not all of them, by the way. It's not. There's some drugs that seem to produce antibodies to them a little more frequently than others. So can we test for it? This is an area that is developing. We actually can, and we're hoping that there's going to be an easier, more commercial test available where we can easily test it. Some of the drugs we're able to test for easier than others. You can test for this one. You'd have to speak to, if there's a concern, there are ways of sending the blood to certain labs that are doing this, and it can be tested. So if you carry or you're producing a lot of antibodies against the drug, theoretically the drug won't be working as well anymore. How do we counter that? We counter that by giving other medications at the same time to reduce the antibodies. So you'll often see that it'll be recommended to combine a drug like that with, say, methotrexate. Okay, so not to take away the methotrexate, but there's evidence that if you have the methotrexate on board with it, we call it combination therapy, you can actually reduce your antibody formation, and it could help the drug to work better and to stay working longer. Okay, but it is available.
Okay, thanks.
I think it's very eye-opening on the lecture here. I'm on methotrexate right now, but how do I know when I should change to the biologic?
Okay.
When should I ask for it?
Right. So again, a great question, because as a patient, right, how do you know exactly? What are you supposed to be looking for? So I'm going to back up for 1 second on that question, because I think what should be happening is that at the very beginning of this, you should be having a discussion with your doctor about what are the goals of the treatment here. All right. What are we looking for? Where do we want to get to? All right. And the bottom line is, our goal now is what we call remission. That is our ultimate goal. Remission meaning disease-free. The disease is completely quiet. How do we measure that? What do we look for? We do a physical examination. We pay a lot of attention to the swollen joints, and we actually count them in the office. So we don't like swollen joints. We don't like to leave people with swelling because, as the pictures I showed you, if we leave that swelling there, we get damage. So we want to turn off that swelling. So we'll look at the patient and see, do you still have swollen joints? Second, we will do blood testing. So we'll look at the inflammation measures in your blood, something called the CRP, C-reactive protein, or the sedimentation rate. These are measures of inflammation. If you still have swelling in your joints, if you still have inflammation in your joints, by measuring in the blood, if you're still having trouble functioning the way you want, all right, those are all signs that maybe you're not doing as well as we'd like on a drug like methotrexate. Maybe we need to move on and push a little harder. Many of you who are patients here will have filled out little questionnaires sometimes in the office. That it's called the health assessment questionnaire, where we'll ask you to log how you're functioning because of your arthritis. And we'll actually do that from visit to visit. So that's another important thing. That's called a PRO, patient reported outcome measure. So we'll take all of those things together. We'll look at how you're functioning. We'll look at your swollen joints. We'll look at your blood tests, and we'll make a decision. Now, everyone's a little different. Sometimes we can only do what we can do, and we have to be satisfied with leaving a little bit of inflammation in the situation that you're in, and we don't push harder. Other cases, we keep pushing, trying to achieve remission. It's just that remission is not always obtainable. So it depends how bad the case is, how long the patient has been afflicted by this. I mean, if you've had rheumatoid arthritis for 20 years, remission's a tough thing to achieve. If you've only had it for 6 months, then absolutely, you know, that early patient, we push to try and get the patient to remission before it gets too established. All right. So it's case by case, but those are the parameters that we look at. Okay.
Thank you.
Okay. Sorry, where's the question coming from here? Ah, sorry, I can't see you. Do you want the question at the mic? Yeah, that's okay.
So similar to her question, what's the point of doing the second line? Like, what's the point of wasting time on the plaquenils and methotrexates? Like, why aren't we going to the biologics straight from the get-go?
That's a politically loaded question, I think.
So it's a money question in the end.
Well, no, I wouldn't say that completely. Okay, you have to sort of take a step back. First of all, let's talk about methotrexate, because that's kind of the main second-line drug. There's other ones, and we combine them with Plaquenil or sulfasalazine or leflunomide or Arava. They're all second-line drugs. So there's a couple of points to be made. First of all, absolutely, they're cheaper. Okay, hugely cheaper. Okay. Second, they could work. Okay, and they do work in some people. Okay, they do. I mean, I have patients who never need a biologic drug. You know, I would say biologic use is probably in the range of 30%, maybe up to 40%, but not more than that. All right. And so what it means is not everybody needs a biologic. Some patients will respond very well to the DMARDs, and I have many patients like that without ever having to go to the next level. So we try. Your point is well taken. I can't dispute it because I've had these discussions with colleagues, and we've had discussions about, you know, what would be ideal treatment. And I do believe that the biologic drugs are more effective overall. They are very expensive. There are potential side effects with them that are different. It's not just, you know, you're not just taking an aspirin. You know, you're really ramping up the treatment. Not to say that the second-line drugs don't have potential side effects too. So it's a bit of a roundabout question, but or answer, I should say. But in reality, the drugs do work. If we move quickly, like what I do is I will give the second-line drugs 3 months. That's not that long to wait to see if someone's responding. You know, in the history of like the course of the disease, a lifetime of disease, if I can wait 3 or 4 months to really gauge whether the patient's responding, that's generally worth it. for most patients. For
Okay,
most
but on your
patients.
graph, there's whether your yellow line is like, let's go back to the methotrexate, your plaque, and your line 2s, they're just stalling it. They're not actually improving, whereas
Right.
your biologics are
Right.
clearly diminishing.
It's a question of
right
how
from the
long you
get-go.
wait and what's that critical time at which you've waited too long. That I can't answer it perfectly because we're not actually sure what early disease means. In other words, is it too late once the diagnosis is made? They've already had the disease even before it came out clinically? We're actually not sure. So your point's very well taken. I mean, if cost were no issue, I sort of wonder if the whole paradigm of how we treat might change. It's possible. I can't give you a perfect answer, but right now we are restricted. These are the rules that we follow. And we do see good results, though, with second-line drugs. It's just the key is not to stay with them for too long and wait and wait and wait and wait. That's the key. Give it a certain amount of time and move on. Hopefully, we're still going to catch that window of opportunity and still be able to turn off the disease.
Am I allowed a second question, completely unrelated?
Can I, sorry, I just want to be mindful of time. I want to take one more question in the room, and we have some questions actually through the webinar, so I want to just respect that a bit. Go ahead.
Okay, I had a question, Dr. Starr. So I understand.
Move up a
that-
little closer to the mic, maybe.
Yes,
Yeah,
okay.
perfect.
I understand that biologics do not cause cancer, but what if a patient has a benign tumor already, or maybe a benign tumor with a necrotic core? Could taking biologics cause that to develop into a malignant state?
No, the question again is, could these drugs turn on a potential tumor or something? And the answer is there's no evidence to that. Okay, so what we say is that these drugs do not cause solid tumors, all right, solid tumors. There has been some discussion over the past few years about blood-borne cancers like lymphoma as possibly being increased by the use of biologic drugs. It seems that that's also not the case. If we look at registries worldwide that have been following these things, along with FDA reports and so on, it really looks like the drugs do not cause cancers and don't turn cancers on.
Okay, so even
Okay.
even a tumor with a necrotic core. it doesn't
Well,
really turn
again,
on.
I'd have to know more details about that. A tumor with a necrotic core, I could imagine other problems happening because necrotic tissue is also damaged tissue, which potentially could risk getting infections inside that. So that's a whole other area where you might have to be cautious. Okay.
Thank you.
Yeah.
Just if you don't mind, let me, there's a couple of questions that came through from webinar participants. Dr. Starr, is there any worsening of RA during pregnancy?
Okay, so question about pregnancy is a fascinating one, actually. We used to always say that it was really, really good to be pregnant if you had RA. Okay, so in other words, the RA, and we've seen this actually, the RA almost would disappear during pregnancy. Very mysterious thing. Not quite clear what that is. Some hormonal influence clearly is occurring. That's a little less common than we used to think, actually. We used to always say, if you're pregnant, your RA will go away during your pregnancy. We now know that's not quite true. There's a percentage of patients where the RA probably will go into remission, but there are some where it doesn't change at all. Rarely, I would say, the RA gets worse. So generally during pregnancy, we don't think of RA as getting worse.
Thank you. I'll ask one question and then we'll allow another one in the room as well. Hopefully that's okay with you and you're not rushing off to another
Yeah,
session.
absolutely, sure.
Is there any new types of treatment for RA being researched for treatment of patients that failed all biologics?
Yeah, so that's a tough situation when we run into this sometimes where patients just don't seem to respond to everything we throw at them. And it's very, disheartening and frustrating for everyone. There are investigational drugs. There are clinical trials that are going on, some in Montreal. Most of the new drugs are variations of some of the ones we have already on the market. So in other words, there's new JAK inhibitors and there's new interleukin-6 inhibitors and there's new B-cell inhibitors. For the most part, those are the drugs that are available, at least in Canada, for experimental use. Okay, but there are new things coming as well that are a completely different class of drugs than what I've shown you.
Thank you. Go ahead.
Yes, thank you. Dr. Starr, my question is specifically regarding biologics versus biosimilars. And I'm a little concerned whenever it is a question of money, cheaper versus within what other generics are done right now in the population, and we are not always considered exactly the same. Now, biologics versus biosimilars. Now, let's say you have a patient in remission, and as you mentioned, it's not always easy to achieve, on a biologic treated for several years. Would you consider a change to a biosimilar?
Yeah, you're asking a tough question. So the answer for me, and this is a personal take on it, at the moment, if I have my patient on remission on drug X, okay, I'm not anxious to change them, personally, okay? I do not want to. I'd rather them, if I've achieved stability, I would rather keep them stable on the current drug that they're on. Is it logical? Do I have a reason to fear switching to a biosimilar drug? There's research going on right now looking exactly at that question. There's a study that's going on in Norway. That's going to be, part of the data is going to be presented in November at the American College of Rheumatology meetings in Washington. So I'm anxiously looking to find out what the data shows, but I believe that it's going to show that it's safe to switch and that there's no loss of efficacy when you switch. I suspect that's what will be shown. And so I'm still reluctant for my patients to switch or be forced to switch. If I've achieved stability, I would rather keep them like that. That's, I'm not answering you directly, I know that. Whether I'll be forced to switch from a cost point of view, whether payers, either insurance companies or governments, will come in and say, look, we have cheaper alternatives, you have to try this on the patient, or we won't cover it. That could happen. That could happen. It's happened in other countries.
Okay, now you mentioned the Norwegian.
Sorry,
clinical?
just to go back,
Yeah.
so far what I know about the biosimilar drugs,
Okay.
it's not the same, it's much more complex than, let's say, making a copy of an aspirin. Okay, these are very complex molecules, they're antibodies and so on, very, very complex, not so easy to make copy, but the companies that are in this business doing this have, from everything I've seen, have done a good job with them, and they look to be pretty effective and pretty similar. So it looks like they're here to stay.
Yeah, we're talking similar but not exact. And that's what is like kind of concerning. Now there is a study, and I believe it's the first study on major international study on biosimilars. While we have, say, 10 to 15 years experience in clinical trials with biologics. So right now we don't have the same, if you want, data to prove that they are.
Well, we don't have the same data on biosimilars that we do for the what we call the innovator products that started this all. However, I'll caution you to, I'm getting the feeling that you're sort of
I'm concerned,
you're very
yeah.
skeptical and concerned, which you have a right to be. We are too. We've asked a lot of questions about this, but from everything I've seen so far, I'm not sure yet that I've seen a problem with them. Let's put it that way. Okay, so you might be skeptical, you might be a little concerned, but I'm telling you that they're here to stay, and that for what I know about them, they seem to be effective and safe at this moment. We don't have the same years of research and experience with them. That is true.
Yeah. Could it be considered eventually for newly diagnosed patients only?
Absolutely. Yeah. Yeah.
Thank you.
Thank you very much.
Thank you again, Dr. Starr, and thanks to Pfizer again for making this possible. Thank you all for joining us. Please do complete the evaluation forms, leave them in your seat, and we can pick them up. Enjoy the rest of your day.
Thank you. Thank you.